And Ellen, I'll turn it back over to you. Thank you.
Thank you very much, Donna. One of the things that I'd like to talk a little bit about before we get into this webinar is why this webinar came about. This webinar in particular, as well as several that will be coming up, you will see that we have tried to develop these webinars in response to a training that was done in Georgia discussing best practices for controlling TB and corrections. You will hear us periodically referring to information from that training and answering some questions during this webinar that were raised at that time. We recommend, if you have not attended that training, that you do so, and we will try to make one available prior to the next webinar. If not, it will be directly after that. It covers the basics of TB and TB transmission as they relate to a correctional facility. And we all know that sometimes there are challenges trying to fit community standards into a correctional facility. And so we're going to be looking at that as we go through this. As you can see, we are pretty comfortable with talking back and forth, and we really want your interaction. So we're going to do a series of things with you, and you just use those annotated, tools down at the bottom. And so the next thing that we're going to do, this is arresting TB, reducing transmission to keep your facility safe. And hopefully by the end of this webinar, our goal is to try to help you think a little differently, maybe think outside the box. What are you doing now? If it's working for you, great. If it's not, maybe raising your awareness. So with that, our very first question is a question that we'd like you to type on the board. What is the one question you hope to get answered by the end of this webinar? Go ahead and use your tools. I know I'm making you think. First thing in the morning. Hopefully you have your coffee.
Here we go. Some people are starting to write. They need to think a second, and this is a longer one.
This is.
So. And don't worry about where it shows up on the screen. I will do some moving around. Okay. Someone's got a check mark going on. You just need to click on your capital A, lowercase a. Okay, please don't delete.
I wrote that one down.
Okay, great. Okay. You get a few here. This is wonderful. We'll give you a few moments here. We know this is a longer item that you have to think about and then type a little bit. Don't worry if you're typing over something else. I'll move those around in just a moment.
Excellent.
Hey, you're getting some great questions in here, Ellen.
These are fantastic.
And I know that helps you to make
Yes,
sure you're covering items or letting them know when you will. Okay, I think I'm not seeing any more activity going on at this point, so I think that
I think we've pretty much got it. These are great.
Wait, we're getting one more. This is good.
Perfect. And as you're typing, let me just read a few of them. What tools are needed? We're actually giving you some of those tools on our website as we speak. They are posted on the What's Happening page. You go onto the first page and you can just click on it. What some of the best practices are, and you will see as we go through this particular webinar, as well as several others, we try to infuse some of those best practices. So we will hopefully help you to gain a better understanding of infection control and the policies and how to apply them. That's a real challenge in corrections. TB educational materials that work in corrections, and what do you need? Better access to TB reports. I love that, especially from the labs. As you can see, typing skills do not matter in this. We can pretty much figure it out.
It's okay. It's really fine. Don't worry about it.
Oh, no, it really is fine. And how the state office can assist correctional facilities in developing working policies and procedures. That is one of the most important pieces because, as we've said many times, you who work in corrections know corrections very well. And you've probably heard me say this many times, that even though I worked in a correctional facility and did infection control, I was a certified infection control nurse, I thought I knew all there was about TB. And when I finally got to the state health office and started learning about this one disease, I realized there is a lot to it. So you in the public health sector will realize that you are the experts in TB. You live, eat, breathe, and work in there. So my hat is off to you and to all of you who try to work with TB and this challenge. So I think we're pretty much set. I'm going to go on to the next slide and just talk a little bit about a case example. And this particular case example, we will go through this webinar referring back to this case example. 28-year-old Hispanic male, incarcerated June 1st of 2008, and the dates really don't matter. What the question I have for you is, has this ever happened to you? They were identified in intake as a previous positive skin test, and their last incarceration was 4 months prior. The inmate stated he had 6 months of INH, not documented, and he actually was identified with symptoms of cough. He denied any weight loss, but his clothes looked very loose and very baggy. They looked at his prior incarceration picture, and it showed a much healthier looking person. Intake is a very important area, especially for stopping TB at the door. You really want to try and keep them from going into a facility and spreading their germs. So anybody who has symptoms, and this is the difficult part, because if you have somebody who just got through with a crack house, their lungs, they're coughing up all kinds of stuff. So you really need to look at and put all the pieces together. And the officers can really help you with this by doing some education and training in your booking area. Those are the guys that are going to probably recognize these people. So you need to try and isolate them immediately and have them evaluated. This is not an easy task. Unfortunately, the scenario is business as usual. Sometimes we may see these problems. So with that, you have this patient and been sitting there, and after 2 weeks, the inmate puts in a sick call, my cough won't go away. Now I'm spitting up blood. And here's where I want you to help us answer this next question. What would you do next? Would you mask the inmate and obtain a chest x-ray? Would you have him wait in the clinic until he speaks with the clinic doc? Would you place them in segregation until a negative airborne infection isolation room is available?
So you're not on here.
And somebody has not muted their phone. So if you could, please put your phone on mute, not hold. As well, place in segregation.
Star 6, please. Star 6 on your phone pad.
Thank you, Donna. As I said, we're really laid back here. We just, sometimes those side conversations may have a patient's name, and you don't want to do that. And the fourth one is check with Health Department HIV program. So click on your polling choices, and I see several people have. Many of you say mask the inmate. Some of you place in segregation. All right. Most people are saying mask the inmate and obtain a chest x-ray. 70% of you said that. Great. All right. Well, interestingly enough, you're all pretty much right. Masking the inmate and obtaining a chest x-ray, absolutely. Spot on. You don't want to have them wait in the clinic until speaking with the health department. That's probably not a good choice, and nobody chose that, so I'm very glad to see that. Place in segregation until you have a negative AII, or airborne infection isolation room, available. The best practice is to isolate them immediately, but also isolate them with that mask on them. So you were both right. Begin that discharge planning because you really want to talk to the health department and find out what's going on. And the health department needs to have information in case this person, for whatever reason, gets dropped out of the system. You want to ask some questions. Who will they live with? Where are they going to go? Where do they like to go for recreation? Is there a favorite bar or a favorite hangout that they like to go to? Who are they going to, who's probably their next of kin? And what do they like to do for fun? All of these questions can aid the health department in locating this person if you're not able to have them come in and talk to this inmate and get the questions taken care of. There are a lot more discharge planning questions, but these will help you to begin that process. And we actually, down the road, will have in a few months a specific webinar just on how to develop discharge planning for corrections. So look for that one as well. So one of the questions that is asked is, what is TB infection control, especially in a correctional setting? And we went to Free Dictionary just looking at some, most of the, quote-unquote definitions of infection control, and it truly, most of them said, infection control refers to policies and procedures used to minimize the risk of spreading infections, especially in hospitals or in human or healthcare facilities. And that's pretty much a good generic response. But for the purpose of this event, we really are talking about the policies and procedures that you have in place to minimize or reduce transmission in your correctional facility. It's all about keeping your facility safe. Officers, when they say infection control, that's not my problem, I don't have to deal with it, they actually have to deal with it because safety is their number one priority. And safety, not just referring to inmates fighting or people bringing, contraband in, it's also about maintaining the safety of the inmates. And I say that because liabilities happen in correctional facilities. Nowhere else does your patient come with a lawyer attached except in a correctional facility. And so with that, you have to look at what is it that's going to impact my facility the most. And one thing that I just was notified about was a class action lawsuit that happened because of a TB case very similar to this particular case that we just talked about. They came into a facility, they had a cough, they complained, and because they complained of a lot of other things as well, they went to work, they were cleared for work release, went on work release, and unfortunately they found out after the fact that this person had TB. And several inmates, as you can imagine, were infected with TB, as well as a couple of officers and a healthcare worker. And their class action lawsuit just now was settled for $10 million, just because of one TB case. And you don't want that to happen in your facility. So these are some ways that you can help work on that. Why is it so important? Well, let me just say that we may never stop TB from entering correctional facilities, but we absolutely have the ability to stop the transmission. So with that, let me just give you a little bit more background. And some of that background is statistics, and, you know, there's all kinds of statistics, but corrections, there are currently 2.2 million individuals in prisons and jails, just in the United States, and about 10 million people who are booked in and out into about 3,400 U.S. jails every year. That pretty much constitutes 1 in every 32 adult Americans that's in jail or under supervision. And this is all on the Bureau of Justice Statistics website, so you can retrieve the data yourself very easily. For Georgia, and again, we are doing this webinar in response to our Georgia folks, and so for Georgia, in 2007, there were 27 cases diagnosed in their correctional facilities, and that's all their facilities. In 2008, it was 28 cases, and in 2009, again, 25 cases were diagnosed, and almost twice the amount of African Americans or Black Americans and Asians were diagnosed over the last 2 years than whites. This is really important information that you in your health departments need to understand and need to see. Talk with your state health office. Talk with your local health department people to find out how you can get these statistics, because it's really important to find out what's happening in the community and in other facilities, because inmates transfer back and forth all the time. So, with that, we have one more polling question before I turn it over to Sue. Do you have a written TB infection control plan for your correctional facility? Go ahead and click on your best response. And we really would like the health departments, if in fact you know that they have one, please also answer. I see a few not sure. That's good. Yes, but only a few policies. Good. And the no, I think only a few policies have TB in them. I have to tell you, for Florida, most of that's a lot of what we have seen in the past. So I don't know. It looks like we've got a lot more that are saying they have a completely separate from other policies and procedures, which is fantastic. Aren't these fun? I love these. If you do have an infection control policy or plan in your TB control plan, what's included in that? Please take a moment to just document, write it on the board, just in a few words or less. Is it just about the inmates? Is it all-inclusive, and it says inmates as well as employees will be tested? Is it mandatory? Is it not mandatory? What about TB treatment? All of those things.
We're getting some answers. Just a reminder, down at the bottom, go ahead and click on the A, the capital lowercase a, and then click on the screen, and that's what will, when it'll be, you'll be able to type it in. There we go, getting a few of these.
Great.
Everyone's getting really comfortable with the whiteboard. It's wonderful. Several of you were on that all-day webinar and got real comfortable with it.
This is Nurse Bogart, and I was late joining, but I'm unable to get to the downloads on being where you're at right now. Could someone help me?
Okay, so you're not seeing our screens. Is that what you're telling me?
Correct.
Okay. Were you have you tried to get into Live Meeting and are having troubles with that?
Right.
Okay.
It's saying
Go ahead. It's saying what?
whenever I went to the point where I'm supposed to log in, it's asking for the chairperson. And I've tried several ways. I've tried putting in the telephone number. I've tried putting in, the code that was given to me, putting the attendee, but nothing seems to work to get me to that.
Okay. I'm going to give you a phone number to call. Ellen, go ahead and give our main number.
The 352 number?
For, yes.
Oh, okay. It is 352 273 7682. And if you go ahead.
Ask for Karen.
Yes, that's what I was going to say.
Okay.
Okay.
Perfect.
Ask for Karen, and she can help you try to get in there, okay? And then you'll be able to call back in and join us. Thanks.
Okay, thank you.
Okay. All right, Ellen, it looks like we've got several here who have given us some, yes, they've been busy.
Yes, they have. This is great. Pre-treatment evaluation, all treatments spelled out, excellent. Mandatory testing for inmates and employees every year. INH and B6 therapy, routine PPDs for inmates. Find suitable housing for inmates, very good. Testing for positive staff exposures, treatment, and utilizing that health department, excellent. These are all great, great comments. Okay, with that, I'm going to go ahead and turn the time over to Sue Lane. Sue, are you available?
I am. Can you hear me?
I love it. Yes.
Okay.
Do you have anything more to add to what we said in the beginning?
No, I think that you've covered quite a bit, Ellen, and one of the things that people don't realize about correction is the security end of it and working with security to make sure all these things happen. And like Ellen pointed out, they always think, well, it doesn't affect me, and they don't think that until you have an outbreak, and then it really affects them, and they'll be talking to you.
That's exactly right. And with that, I am going to turn the time over to Sue Lane, who will be talking about the hierarchy of infection control and corrections and talking about every one of these issues. So, Sue, let me go ahead and I will move the slides for you if you want, if you're okay with that.
I am. Good morning to everybody. And thank you for joining us this morning. We're going to look at the hierarchy of the infection control program in corrections. We're going to look at the administrative controls, environmental controls, and respiratory protection controls individually. And we'll follow the case that Ellen presented at the very beginning. So we'll follow that case along and how it affects in each one of these sections. Now, your administrative controls, they're the policies and procedures that we just talked about, and they should be in place. And this will help reduce the risk for exposure, and it's for an effective infection control program. You actually need to assign a responsibility for the TB infection control. So if your correctional facility has not assigned anybody for that, then you need to work with them and help them to identify how this is going to happen. It's very helpful when the correctional medical staff, the health department, and the security conduct a TB risk assessment and develop a written TB infection control plan. And these should include a lot of things. One of the things it should include is all the precautions you need to be taking. Case management of the TB patients. What is your timely lab processing, reporting? This includes labeling communications. When you send those things off to the lab, if they are actually labeled correctly, you missed a time, you missed a date, particularly in the serial sputums, they're going to say wrong labeling, so they're going to call you, or they may not call you. You may have to be calling them. What's your turnaround time? The mislabeling and the turnaround time are going to be key importance of getting these patients identified and diagnosed, because in a correctional facility, they can be out your door very quickly. Case management of these TB patients. Who's going to be following their cases? Who's going to work with them? You also need to look at the testing and evaluation of healthcare workers at risk for TB or for the risk exposure. The healthcare workers that are working in the clinics, that are working side by side with the patients, and as we call them, inmates, we try to encourage our staff to call them patients because they are patients. But they need to be tested and evaluated, particularly if they're going to be in a high-risk area. They also need to be trained about TB infection control. You'll be surprised at the number of healthcare workers that do not have or don't remember anything about TB. So you want to look at how often are you training them? Are you doing it at orientation? Are you doing it annually? These are very, very important. Also, the appropriate usage of signs around the area. Put up the cough etiquette sign. If you can get them off SNTC, you can get them off CDC. Make up your own, whatever will work for you. But make sure everybody understands what cough etiquette is. Put it in places that both the inmates and the deputies and visitors can see. You're trying to protect everybody. Then we're going to look at environmental controls to prevent and reduce the concentration of droplet nuclei. So we don't want to spread the TB. That's our biggest concern. This is going to include immediate isolation, like we talked about before, of anyone with symptoms, especially if they're coughing. Now, they'll come into intake and you'll say, are you coughing? They'll go, no, I'm not coughing. And they will continue to cough through that. So not only use your assessment skills for what they say, but also looking for what is happening. Just like Ellen was talking about, the guy did not say he hadn't lost any weight, but yet he had on real baggy clothes. And that can be a trend nowadays. So keep in mind what you're looking at. You need to monitor your negative airborne infection isolation rooms or your AII rooms regularly. And you need to monitor manually, even if you've got gauges and they're running in good condition. You just need, a lot of times gauges can get stuck, so you need to look at these. Making sure also that the staff and the security staff know that the food traps do not need to remain open just because they're getting a food tray. Get the food tray, close the trap. When they finish, they can knock on the window or they can actually let you know that they're done and bring it back out. When you open that food trap, you're going to change the airflow of and pressure of the room. And you need to be monitoring the ventilation systems within the cell. Then you're also going to look at respiratory protection controls. This is to further reduce the risk of exposure in special areas and circumstances. So it includes both the security, custody staff, medical staff, and others who might be coming in and out of the cell, clergy that come in and out, the mental health professionals, special care providers like physical therapists. So it's not only just the two, security and medical, it's other people that come in and out of these facilities. Now let's look at how you screen for TB. And if you will, are they going to be able to mark this, Ellen?
Yes, they'll have a check mark. Just use your check.
Use your check mark. And how presently are you screening for TB? And you check each one of those that apply to you.
So go down to your annotation tool, click on the check stamp, and then there you go. Some people are starting to do it already and start checking the ones that apply to you.
Thank you, Donna.
Thanks, Donna.
And you know what? An arrow works also. We don't care. That's fine. Any of those stamps work fine to indicate.
And if you put a check mark over the other check mark, that's good too.
Yeah, that's fine.
Oh, this is wonderful. Look at this. We're starting to get some answers now.
I love that last one. Thank you very much. Yes. I like the last question, guys. We'll go over that in a second. And I think Ellen and I both have heard this many times.
It's interesting. We're getting answers all over the place, aren't we?
Yeah, it's fabulous.
Yes.
In the clinic. During sick call.
Still getting some answers. This is great.
Okay. Looks like each one of these is good. Okay, there's no wrong answer except for the bottom one. I really have a question. What, I have to screen and do a skin test too? This is always a fun question when you look at somebody. You say yes. Depending on your facility and what they've chosen to do as far as their standards, is they have to decide: are they going to do it at intake when they first walk in the door, or are they going to do it later on at the H&P? But everybody should be screened for symptoms. If you're only doing one or even two of these, you may be missing possible cases. You got that, Donna?
Yeah, this is great. Move forward. That's fine.
Perfect.
Okay, and that doing it at every medical encounter, because the person that comes in each time that to your medical encounters, and all of a sudden you've been treating pneumonia for 6 months, and he gets a little better with Levaquin and a little worse, then you may be missing something, and you have to help your healthcare providers. You remember your TB people are the ones that are going to have to come and say, you know, think about TB. Now, we're looking at administrative controls a little bit more in depth. Is this your administrator thinking that they're just gliding along, doing everything's going just fine, don't have anything to worry about, and all of a sudden it happens? The TB alligator raises its ugly head, and all of a sudden you don't have what's in place that you need to do. So what do you need to do before this happens to you? First of all, it's your facility administrator is going to be involved in your policies and procedures, along with your security staff, because you have to look at everything. You need to make sure that whoever is assigned the responsibility for TB infection control in the correctional facility knows what is expected of them. They also need to do the risk assessment we talked about. Find out, and working with the health department, security, and medical, so that everybody knows what's going on, what's the risk of your facility, what's going out in your community, because what's in your community will be coming into your facility. You need to develop and institute a written TB infection control plan, policies and procedures specific to TB and medical and custody. Review these. You have to look at, for custody, they're transporting these patients. What's keeping them safe? So remember, security takes leads in a lot of policies and procedures, and you have to work with them to make sure you have an effective plan so that everything works together. What is your policy? Does it match? Are you doing what is right and what is expected and what is the community standard? You also need to look at your policy and procedure for the program evaluation. So you have to evaluate your program, not just put one in place, but evaluate. Is it working? Have you had some issues? You need to monitor your TST. Are the TB skin tests for the inmates? What are you doing? Are you keeping a log? How are you tracking these? Are you looking at them on a regular basis? How often are you looking at them? Are you doing TB skin testing for employees? Who's getting that information? Your TB infection control person should be looking at these on a regular basis. Is security mandated to have TB tests, or are they not? The TSTs sometimes in some facilities are not mandatory. They should be, but I have seen facilities that do not have that, and it has to do a lot with other issues. Also, you have to look at your labs. Where are you sending these? What's the availabilities? Are you doing the IGRAs? If you're not familiar with that, it's interferon gamma release assays. And if you're not familiar, we're not going to go into that. There's a webinar that is actually archived with SNTC. But you also have to look at what you're doing for your labs. Is it the IGRAs? Is it the sputum? What is actually going on? What's your turnaround time? Make sure that these are available. Make sure that you have the contact person, because when you need it, you don't need to be looking for it. You need to have it in your policy procedure what to do next. Training and education. As before, who's getting it and how often? Everyone should be trained in tuberculosis. They may forget it, and you have to re-educate a lot of times. You need to coordinate efforts with your local and state health departments, and it's so important that we maintain that between corrections and health departments. Every place I have worked, the health department and I become very, very close friends, because this is working friends, because when we have an issue in the jails, we have to call on them. One person cannot do this by themselves. Remember, your administrator is like the guy in this picture. He can be gliding along just as easy.
I'm sorry.
Excuse me?
Go ahead.
He can be gliding along until TB encounters at the door, and then suddenly he spots that alligator, and that TB problem becomes a big issue with him. Is he going to slide into his mouth, or is he going to miss it by a hair? If you have your policies and procedures in place, the chances of raising that alligator's head is going to be less chance. Okay, let's look at something a little bit further.
All right. Before we do, could I just mention that in the handouts that you're able to download, we have one handout on all of these components, developing a comprehensive TB infection control plan. So you don't have to take a lot of notes. We've done this for you. And we've got some logs as far as airborne infection isolation room monitoring logs and respiratory isolation logs and some things such as that. So this may help them a little bit as well.
Yeah, and
just
if
just a reminder here is you would mute your phone by pressing *6 on your keypad. I hear some background noise. I think some people who joined a little later may not be aware of that. So *6 will mute your phone, and we appreciate it. Thank you.
And if you're not familiar with your correctional facilities, the logs for isolation rooms are important. It's part of standards, and following the standards of both the National Commission of Correctional Health Care and the American Correctional Association. So it's very important you keep these logs because they will ask to see them at surveys. Now let's look. I want you to write in again, who do you screen and test? Everybody go ahead and write in. Use your tool down at the bottom.
Go ahead and click on the A and then click on the screen, because before you guys were using the check marks. So there you go. They're all getting to be big pros at this one.
I'm telling you, they're doing great. They're great answers. I'm glad to see this. This, you know, the favorite quote that I hear from Ellen, stopping TB at the door. Very, very important, and this is where we look at it. As a matter of fact, I think it echoes in my brain from time to time.
Sorry about that.
No, it should, because it's the first thing I think of when we have issues. And that's what a lot of people, one of the providers that I worked with stated that, you know, I really didn't think about TB. I really didn't think about TB, and people have it, you know, and they think, oh, well, there's still TB. That's a very, very common thing, particularly in your judicial staff and your community. Okay. Hey, somebody's doing the two-step, and I don't mean dancing.
One thing I will say, Florida Department of Corrections does a second TST at 12 weeks because they found a large number of inmates were actually converting their skin test at that 1 year mark. And so as kind of like a little snippet, the TB control program manager at the state level in Department of Corrections wanted to look at things a little differently, and so looked at that 12-week as a second step for inmates, and found that we could actually, in looking back at those 12 weeks, we could tell where the TB people were, the inmates with TB infection were actually getting infected, and it was your local jails. A large number of them were getting infected there, so that's also another area.
Okay. Now, if you look at your handouts, if you downloaded them and printed them, you should have your risk assessment form. They're in the handouts, and we just talked about it a little bit. Ellen just talked about it and introduced it to you. And it's adapted for the correctional facilities from the publication from CDC in 2006. It is an Appendix B called the TB Risk Assessment Worksheet, and it's located on the CDC website. Remember, you need to work together with your health department, TB program, your medical staff, correctional staff, and do the risk assessment. It includes the scope of risk for TB for the specific incarcerated population, as well as the facility itself and other facilities. And they may contract with, like, ICE, other jails, or other prisons to house people there. So you got to look at what is your risk assessment, what's going on in the facilities, and determine what your risk is as far as TB in your facilities. In looking at it, for the correctional facility, you also want to look at the number of conversions you have. These should be looked at over a period of time, and it's especially important when you have a TB case that you're not aware of. And if you're having conversions, you don't know of an active case, then you're going to have to be looking at the source of it. So let's look at, Ellen, do you have anything to add to your risk assessment?
This particular risk assessment is actually adapted from the CDC one, and this is specific for corrections facilities. Can be used in any correctional facility, and really looks at the risk classification of what the risk of your facility is in relation to your community. So I don't know if that helps a little bit.
Okay, we're looking at now, we're going to take a look at the conversions of the TST, the Min2 TST. The CDC definition of a conversion is the change of a TST negative to a TST positive. Now, what constitutes a positive? An increase of greater than 10 millimeters in a TST reaction size within a 2-year interval. There's your conversion. When you look at conversions, you'll want to identify why this person may have converted their TST. If it's an inmate, if it's a staff member, if it's security. Is it due to a contact to an infectious case within the facility? Or was it in the community? Were they around other people that they had symptoms that they know of, or somebody else that they may have known in their area that may have been diagnosed with TB? If you can't identify this person who's developed a positive from a negative TST, you will need to look for a source. Okay? So we're going to have converters, but have no active cases. We become a source case investigator. Crusoe. We inspect. We become inspectors, investigators. We have to find out where this is coming from. The source case investigation seeks the source of a recent MTB infection, perhaps a newly diagnosed TB disease. You look at your MMWR guidelines for investigations of contacts of persons with infectious tuberculosis in 2005. You're going to monitor your TSTs like we spoke about earlier in the conversions in your facility to identify whether one is needed. You have to look at your staff, your inmates. You may have other people coming to your facilities. You may have to look at them. Look for clusters. People coming in. I have 4 facilities here, so I look for facilities in the areas, not only there, but in the actual housing locations. In looking for a source, it's important to identify these clusters that can lead you to the TB disease. Maybe somebody has not shown the signs or has not mentioned the signs, and nobody's actually noticed. They just think maybe they got the flu or a cough. If evidence isn't there, you're going to have to be able to make the determination of where it came from. You're going to ask a lot of questions, such as, are there documented recent converters in that area? Staff coming up with conversions, security staff coming up with conversions, inmates that have been there for a while, are they converting? Is there an increase in one area? Did the number of positive TB skin tests increase by at least 10% in a given time? Are there serial TSTs? They're a way of actually identifying if your TB control plan is working. If it's not, also, we'll look at both sides of it. Review annual staff skin tests, and you can identify clusters or increase in positive skin tests in the specific areas. Is there an increase in one area over another? You identifying clusters in the inmate population. You may be able to note an increase in positive rates. You're going from all of a sudden you have 30 positive TSTs, and the next month you've got 60. What's the reporting factor of that? Look and investigate. Why is that? Is it because there's a source issue? If the facility is a long-term, then annual TSTs will assist you in monitoring this as well. And then we're going to look, is there a problem in this facility? Look at the list here. And in the housing units in the facility, this is listed as Unit 1, 2, 3, and 4. You see that 90s were tested. Of the inmates, 2% or 2 were positive in Unit 1. 1% of the staff was positive. You're going to be reviewing these by seeing the TST logs over 3 months, and that's what you're seeing. 87 in Unit 2. 3% or 3 inmates were tested positive. In Unit 3, 102, 2%. And then all of a sudden in Unit 1, you tested 101 and 31%, and 3 staff members are positive. What happened here? There seems to be a problem in Unit 4. Does everybody agree with that? With a number of TSTs identified and staff conversions as well, there may be a TB source that hasn't been identified previously. And it could be someone who's there that hasn't shown any signs or voiced any signs or told anybody he's having a cough. Or he could no longer be there. He passed through, was there for a while, and then left. And then next month, you may have this Unit 4 may have no conversions or minimal. So these are things that need to be identified when looking at a source. Is there an ongoing transmission, or is it just a one-time change? And we're going to look at environmental controls now. We go along on a daily basis doing our daily routines, and every day is a little different, and we're plodding along, and we think we've got everything in place. We haven't checked our policies and procedures. We haven't looked at our environment, so we're looking at environmental controls, and all of a sudden we see this beautiful day. Is this the way you think of it? Just a going along every day with the policies in place? Primarily, environmental controls are just that. They control the source of infection. We monitor negative air rooms, and they're very important. We ensure the airflow pattern is flowing in the right direction and is essential and must be monitored at different times of the day. And also, at different locations, you'll have different types of systems, so you need to know what's there. It's a change in temperature. If you have a fluctuation in temperature, this may become a problem. You need to know your airflow areas, what's going where, and who's sharing air. The secondary control includes the cleaning of the air once it's entered the air room, and it's consistent of a UVG and a HEPA filter. And not every isolation room has all of these, but you should. And if you don't know, ask. Work with maintenance to ensure that safety is in the environment, because they're responsible for the airflows and the air conditionings and what they're filtered through, where they're going to the outside if they're sharing. They will know what to look for. And remember, environmental controls consist of primary, which is controlling the source of infection. So if you don't have everything in place and you don't know all these things, what happens here? If you look at the picture now, it's changed to a tsunami. The TB tsunami has happened. You found a case, nothing was in place, and now you're struggling to get everything under control. You're trying not to do like the little car and run for your life, but you're trying to make a stand and make sure that nothing goes further than what it is now. You need to control the source of infection. You need to monitor the negative air isolation rooms and control the airflow. And you also need to make sure that the air is being clean. Planning ahead is much easier than trying to handle the situations or problems as they come up. By not monitoring these areas, you can go from a relatively nice day with all the boats and Sprite to the nightmare of a TB tsunami. Okay. Is everybody still there? I got 31 people. I really appreciate you guys being here. And let's go look at the isolation rooms. What is an isolation room? And pretty much everybody that works in the health department and TB programs know what an isolation room. It's negative pressure. The air flows into the room and not out. They're also identified as an AII room, or an airborne infection isolation room. This is per the 2000 isolation guidelines from CDC. And you should be monitoring these daily if they're occupied, or every shift, depending on where you are. If you have someone that's in there that has an airborne infectious disease, then you need to be making sure that there's no change in that or shift in the airflow. Are you keeping a log? And as Ellen pointed out, we have handouts with the logs already printed out. Feel free to use these and use these and adapt them to your area. If it's not working, do you know what to do? Okay, which brings us to our next topic. What do you do if you don't have an isolation room, or if it's not working? Use your tools down below, the A's, and what would you do if your isolation rooms are not working all of a sudden, or you don't have an isolation room and you get a TB case? What are you doing? Go ahead and write on the board there.
Here we go.
Call the maintenance. Good. And this is happening on Saturday morning, or Saturday night at 11 o'clock. So you got to look at all aspects. Corrections is 24 hours a day, just like the hospitals. I love your answer, masked inmate. Placing in the cell away from population, that's great. Housing another jail. There you go. These are all great answers. So you think ahead, and thinking ahead will help you so much. Keep in sunlight. If it's at night, it's not going to help, but if it's during the daytime, we can definitely find a recreation area we can put them in, as long as it's not in cold weather. Put them outside. Okay. Very good. Anybody else? Okay, let's look to hospitals. They require, you can also send them to a hospital. That's okay. And you caught that one great, the other correctional facilities. Now, some people might want to release the patient. Not really a good idea. You got the sunlight. I mean, y'all are doing great. Keep the mask. Very good. Y'all did excellent on this one. Okay, let's look at monitoring the negative AII rooms. Okay, if you look at the picture that you see up there on your left, you see a security person looking up at the thing. And it's a vent at the very top up there. Inmates are notorious for, it's cold in my room, so they take tissues of any kind, and they will wet them however they do, and then they'll throw them up against there and block that vent. And that is going to take the airflow into a positive. You're going to have to be careful, and you'll have to watch this. So you're going to have to monitor those vents, and if they're not where you can see them, monitor them on a regular basis. In order to monitor them on the outside, you look at Ellen there. She's actually, you take a one-ply tissue, and believe you me, I have not found one jail or correctional facility I've been into that has two-ply tissues, so there should be plenty for those. And you hold it 1 inch above and 1 inch out from the bottom of the door. If you see it flutter, the direction of the air should be clearly visible. So you look at the little tissue. If there's adequate negative pressure, the tissue will be stuck completely under the door. And remember, you should use negative air rooms whenever there's a suspect or active case of TB. Very important. Now, we're going to take a quick look back at our case example. We're looking now, we've gotten his chest x-ray, and it shows bilateral infiltrates. We cannot rule out a pneumotic process, which is always a scary point for me. So you ask the question, is it bilateral infiltrates? Anything abnormal? What are they actually seeing? We'd like to know more than pneumotic process. The sputum collected as results are positive. This patient is infected. He has active tuberculosis. You should place him in a negative air room as soon as possible if he's not already there. He should have already been there because he is a suspect. This will halt the transmission. The medical and health department staff can identify the contacts. So as soon as you, as a suspect, you need to start your investigation then, and getting your information of who he's been in contact the most should start as soon as you suspect him being a case, because it's going to take you a while to get everything together. And you're going to identify the contacts, and then we're going to discuss this later at the next presentation. A lot of times the health department and other people consider all people in correctional setting as a high priority, but you should be actually doing a priority list according to their immune system, HIV positive, diabetes, their encounters, how long were they with this patient. And remember, general guidelines, there are no formal studies being done that have identified time frames for incarcerated populations, so that hasn't been established. Normally, they've been spent 4 to 6 hours, a bunkmate in a two-man cell, an open dorm for 12 hours. Where's the airflow coming from? So once we've identified all this, what are you going to do next? There's a polling question up there. I want you to go ahead and check. And as you're checking this, let me tell you a little bit about this guy. He stated he didn't have any symptoms, never complained, and a sick call. And he did not go to work for 3 days. The officer gave the staff the information that he had not gone to work. And that's what put everybody on alert. Okay, keep marking. Very good. Okay. All right, we got about 71%. Be certain all the AII rooms are working. Okay, we got one. Well, okay. Call the health department. Keep in mind, there is no wrong answer on this. Okay. Identify the contacts. That's a good answer. It's not wrong, but it's not the best. For those of you who said this, that put that up there and then came back, you're correct. It's good if you identify all the contacts as quickly as possible. However, you may need the assistance with this contact investigation, as inmates have been there for at least 2 weeks, so you're going to have quite a few people. He's been in and out, may have been to 2 different locations, even more. They could be in different housing locations. And you definitely need to check the negative AII room. Is it working? So those of you who said this, you are correct. That would be my first thing. Make sure it's working before you put them in there. You do need to call the health department. This should be one of your first responses. They need to be notified immediately of every new suspect or new case, because they're going to be the ones that are going to catch the ones that have already been released, particularly in jail settings, because they, within 24 to 48 hours and 72, there is about 60% are gone to the streets. Release the inmate and tell them to go to the health department. Perhaps not your best answer, but you know that some people do this. But you think about this. You're part of community health, and you release him to the outside. He doesn't go to the health department, then you've released the case out into the street. And even though they need to go to the health department's going to need as much information as they can, so they'll be certain the inmate releases to a safe home. They may not be able to go back to the house. There may be small children there, or infants, or elderly, or immune-compromised individual. So we need to work with the health department if they are getting released. So let's look at the best practices. I love these. You're going to identify all areas where the inmate has been. It's very important. Classifications can help you. Classifications in a jail setting are the people that know the movements of the inmate. They know exactly where these people are at any given time. They have a record of it. They know where they've been to court, they've come back, what bus they've been on. They know exactly where these people have been and who they've been in contact with, because they have to have that list. You need to identify the airflow patterns. Like we talked about before in environmental controls, you need to make sure you know where the airflow is going, where it's being shared, or whether it's going to the outside and not coming back into the facility at all. Is it a mix of fresh air and recycled air? You need to collaborate with the health department to identify high-priority contacts and review the charts. This is going to be a lot working with the healthcare staff. We're going to have to be looking at charts to see who's been putting sick calls, who has chronic care illness. We have to look at a lot of things. All contacts should be screened for symptoms and prior infection and diseases. Have they had a previous positive TST? Have they had a chest x-ray that was negative? Have they been treated in the past for LTBI? We're going to look at all of these. You're going to need to establish and prioritize testing. And it should be in the high and medium priority inmates and staff of all areas. It should be taken into account. Keep in mind, this is very, very important to keep looking back at our polling questions. You're going to identify the contacts. You're going to put them in the negative room. You're going to call the health department. Working with our health department, and if you're not familiar with TB, the TB health department people are going to be the people that you're going to rely on. They are the ones that can give you the information you need. So environmental controls are very, very important. And next we're going to look at the respiratory protection program. This is where a lot of people like to do if they think there's anything infectious coming up, particularly the security staff. They're not concerned until actually it happens. So is this how you feel sometimes when somebody goes walking in with all this? And why is the respiratory protection program important? What kind of training do you need? Do you need fit testing? What kind of mask do you use? Or should you use? N95, surgical mask, and how do you tell the difference? So your N95 masks are marked N95. So make sure you have those. If it's not marked N95, don't use it. Fit testing, yes, it should be fit testing. And they should also be instructed on how to fit their test and what they need to be looking for. Your policies and procedures should actually address this as far as how can you tell the difference when you're supposed to use which mask and how often they should be changed. It also should consist of minimizing the risk by implementing the respiratory protection program. That is part of the mask fit testing. Have masks available in high-risk areas, such as intake, the infirmary, clinic, sick call carts, the nurses going out to the pods, those medical areas in the housing locations. You also, we talked about earlier, training healthcare workers in custody on respiratory protection. I can't tell you how many times I've walked into an area and the deputies have the mask on upside down and the nose thing is on the bottom. And you have to nicely instruct them that, no, that's not right. You have to turn it the other way. And also, when is it no longer effective? Once they're wet, they have to know that once they're wet, you can't use these masks for a whole week just because you want to keep them. Training will help prevent your officers and staff from looking like the hazmat teeth in our picture. You know, they will actually know. If they know how it's transmitted, they can protect themselves. Now, what are our responsibilities? Well, all the responsibilities are listed in these two books. They're available online at SNTC and on the CDC website. Our public health responsibility is responsible for TB control in the areas. There should be a public health care corrections liaison core competencies handout. And Ellen, I'll let you talk about that a little bit if you would like to.
We don't have it as a handout because you can actually go online at the TB Controllers website, which is nationaltbcontrollers.org, or just put TB Controllers in any web browser and it will come up. On there, you can see our corrections core competencies handout, and it really discusses a lot of information for the public health facilities to actually know a little bit more about the corrections facility. And in doing that, they can help you do a better job in your area when it comes to TB. So it really is about that collaboration and the communication between those two entities, the public health unit as well as the corrections unit, and marrying those two together. It really makes a beautiful flow. And when you have a corrections liaison from public health who really understands your facility, your correctional facility, then you have a better opportunity to stop that transmission within those facilities and looking at things a little bit differently. So thank you, Sue.
Okay. And these guidelines in doing your policies and procedures will become your Bible, because they're what's going to guide you. You're going to be responsible for the standards of care for your facility and what the standards of care are in the community. And it's not just going to say follow CDC guidelines. You have to bring them to your own facility. What works for you, what doesn't work for you, but you have to maintain the CDC guidelines. The corrections responsibility, we need to immediately isolate suspected TB cases. And we're going to discuss this a little bit in just a few minutes on the TB case example. We need to identify and report TB suspect cases as quickly as possible. Provide appropriate treatment and care for TB cases and suspects. Make sure your HCP knows the correct medicines and treatments and testing. I have found from time to time they put them in isolation and they're giving them one drug, INH, because they know INH is for TB. Well, it's a suspect. We need to make sure they understand what the treatment protocol is, and it needs to be put into your policies, procedures, and protocols. It ties into your legal aspects because you're responsible for this. We also do initiate a timely conduct investigation. 2 to 3 weeks after this happens is not appropriate. We need to get on this as quick as possible. This is a quick turnover of people. They're going to be in and out. People will be coming back in. We have to look and make sure that we're catching all of those that might have been in contact and make sure that we're not having the disease transmitted in other ways. We also have to have continuity of care. This includes discharge planning for TB cases and suspects and high-priority LTBI cases. Remember that these two books that we talked about are available online. So make sure that you get these. If you don't have them, make sure you have them in your facility, and you can look at them and refer back to them. Remember, no other place other than the jails does a person come with an attorney, unless I guess you're Donald Trump. Now we're going to look at how TB impacts HIV and other comorbidities. There have been multiple studies on TB and HIV. It's a high risk of progression to active disease for HIV patients. TB becomes the #1 opportunistic infection, and so you need to know the immune status and the TST status of your HIV patients, and vice versa. You need to know your HIV status of TB patients. So you're going to have to look and make sure that you're getting this testing done. Not just the chest x-ray, let's see what else is going on with them. There's also been studies that show co-infection with HPV have an increase with TB, but people that have hepatitis and TB and HIV go from a 14.6% with hepatitis and TB, and if you put in HIV, then it increases their risk to about 35 to 36%. Correlation to HPV and TB you have to look at. So you also look at the medications. Hepatitis is the inflammation of the liver. You have to look. The medications are actually going to affect the liver, and you have to keep up with this. Do they have the risk factors? We look at both TB and STDs. Studies have shown, there was a study in 1996 that showed an increased risk. Now, what this risk was it due to risky behaviors, putting themselves in a position that they were actually in an area that they shouldn't have been, that somebody had like drug uses, drug houses, or they're in close contact with somebody. Anybody has received STD, they've been very close to somebody. We also look at TB and diabetes or other diseases that are immune compromised. It's decreasing your availability of your body to protect yourself from tuberculosis if you have contracted it. Keep it from developing into active disease. We're looking at an older generation now. We have people that have hepatitis C that didn't know they had it 20 years ago. We're having a lot of increases in diabetes, both on the the more advanced age and also in nationally, both young and old. So this is very, very important. There's been multiple studies done on this, and it shows that the increase in the impact of TB on these patients that are chronically ill becomes an issue. So we have to look at those as factors also in the comorbidities of TB. So we have a correlation there. Now let's look back at the case and remember about our environmental controls. You have in the pictorial up here that you see, and you have an A, B, C, and D. Now, this is a pictorial of the conduct investigation that was done. They looked at it because they had an inability to identify the airflow in the facility. The inmates in the additional cells were tested politically because the officers panic. And believe you me, they will panic in a heartbeat. When you say there's TB, that doesn't affect them until they have it in the jail. And then everybody wants to be tested. And this is a time to actually train them and teach them, because this is when they're more open. They want to know what's going to affect them. So there's an opportunity for training and education for them. But if you look at this picture, there were no conversions that the health department saw in Pod A. Now, when we talk about pods in jails, we're not talking about the point of distribution as we do in mass distribution of vaccines and medications. But we're looking at housing units, and we call them pods. And there are 4 cells in this one area, which is called a pod. And you have cell A, cell B, cell C, and cell D. And each one of them have a different makeup. They have one's 37-man cell, one's 16, one's 17, and one's 39. So if you look at cell A, which is where the index case was, as you see, it's in the little square there, his roommate actually converted, okay? So that was the only conversion they had. Well, since there were no other conversions, the health department had determined that no one else needed testing. But in a jail setting, you're going to have a lot of political testing done, and because there was pressure from both the sheriff and the jail administrator, everybody in that pod was tested, and the airflow was checked out. So if you look at cell B in a 16-man cell, there were no conversions. They had 2 previous TST positives. In cell C, there were no conversions. In cell D, there were 39 over half the inmates converted their skid test. Well, what they found out later when they did the airflow studies is that the airflow from pod A to pod D went directly over to a gaming table where a bunch of the inmates sat around playing cards or checkers or whatever they're playing at the time. Directly above that table was a vent that brought the air to them. So if we had gone by what the CDC community guidelines are, we might have missed these people. So you need to follow the CDC guidelines for corrections and look specifically at airflow patterns and recirculation. And if you look, B and C didn't have conversions because they shared air. But the two pods that actually shared air, A and D, are the ones where you had the conversions. B and C never touched the other two cells.
My fingers were too quick, sorry.
Yeah, so you can see the airflow there. So here's the rest of the story on this case. Returning to the case that we were talking about, and as we look at the results of the contact investigation, the latent TB infection contacts, the people that were screened in the facility were done within 1 week. They identified 78 contacts total. 24 inmates had been released, so guess what? They're on the street or to another jail facility or prison facility, so health department or other facilities have to follow up this. The health department is usually put in charge because if they're going to another jail or another prison, then they're probably going to another county. So we have to keep in contact, and that's how we keep a flow of the contact investigation. 12 custody staff and 2 medical staff, 40 contacts still incarcerated, all were screened, and 10 had initial positive TSTs with 1 suspect. Then 30 inmates had follow-up testing in 8 to 10 weeks. So of the 40, 30 were still there. The 30 were still there. 12 of them were negative at baseline, but now they're positive. The results of the contact investigation from the correctional facility perspective. Remember, a contact investigation is not complete until all contacts have been identified by the health. And the health department has to assist with this because they may not always be there. And those that can be located are evaluated. If needed, they are begun on LTBI. Now, for the infection control purposes for the jail, this job was done. For the case management, the job is just beginning. Now you've got to manage this case. And we'll be having a 2-hour webinar on case management in the correctional setting coming up, so keep an eye out for that.
Oh, God, I'm so sorry.
But even with contacts and discharge planning and schedule, we'll talk about this at another contact investigation webinar, okay? All right. All right, on this board, I want you to put on there, list one thing, an item that you learned today that you can begin using on your job. We've covered a lot of ground, and there's going to be more questions, and that's what we want, because the more questions you ask, and the more we can help. We can help give you what you need. Between the two, Ellen and I, we've worked in corrections a long time, and if you are in the health department and not corrections, and you have not visited your correctional facility, then you really need to go out and talk with them. See if you can get in to see the jail setting. Understanding what goes on in the correction facility is very, very helpful in understanding how we have to deal with it. The same with the correctional people. If they will work with you, find out what your job contains and what you have to do, because our daily jobs in tuberculosis change on a daily basis. Even though they remain the same somewhat, they still change on a daily basis. One TB contact investigation, Ellen, you can tell them this, can keep you busy for months, even years.
I was going to say years.
Yeah, exactly. So you learned about airflow checks. That was an interesting thing, and that's one thing that you have to take back to your people, is that just because it says it's a negative airflow, don't bet on it. They can change in a heartbeat, and you need to be able that you've got a record that this has been done. Look back at that $10 million lawsuit. You know, maybe the airflow wasn't being checked. You could look and see somebody was exposed and therefore caused a class action suit. What goes into a policy and procedure? Very good. screening at all encounters is very, very, very important. We just, you don't know when these might raise its ugly head. I've had a couple of cases where they had been here 2 weeks before they developed symptoms. And understand, people coming into a jail setting are very angry, and sometimes they are not going to answer your questions. They are very upset, and then all of a sudden, 7 days later, they realize they're not going anywhere. The judge is not going to let them out. He's not going to let them have bond. The family's fed up. They're not going to have post bond for them. So these people are stuck here, and all of a sudden, then they start coming up with their information. Okay, place a patient outside.
Right.
So you
We
have
have
to
several
look.
people we haven't heard from yet. We would love for all of you to give us some input here. So some of you that are maybe been a little more shy during this session, if you wouldn't mind clicking on that A, capital A, lowercase a, and then clicking on the page and giving us some input.
And if you have further questions, you can always call Ellen. She has a wealth of information. Your SNTC people have a wealth of information. Use them. And corrections, and I'm talking to both corrections and health department, get to know each other. Don't wait till there's a contact investigation. Don't wait until this becomes a problem. Don't wait until you're going for that alligator's mouth or waiting for that tsunami that's all of a sudden you're getting hit by. Because when it happens, it will actually happen a lot of times that not only do you get involved in it, but the media will get involved in it. And the sheriff gets involved in it. So that tsunami includes a whole lot of things. So you want to be prepared, and you'll be ready to take care of whatever's going to happen and do it on a regular basis. And I can tell you the difference in somebody that's planned and somebody that hasn't, and you can see how things run smoothly. Yes, there's the SNTC number, and they will answer your calls.
Thank you, Donna.
Thanks, Donna. Yeah, and placing a patient outside the outside room. But also remember, you have a hospital. If you have to send them to the hospital, they don't like to do that because of the cost. But what is the cost? It's like I tell them, I'd rather pay a couple of $1,000s for a couple of hospital days until I get my flow sheets rather than a couple of $1 million to somebody that got exposed. So when you talk dollars and cents to these people, they actually listen a little better. Ellen, do you have anything to add?
Thank you, Sue. That was absolutely fabulous. We really appreciate your expertise as well, because you bring a wealth of information to all of our webinars. So we want to thank you. And all of you out there, if you haven't written on the board, or if you just think, okay, I really didn't learn anything specific, we'd actually like to know that too. What is it that we can bring to you that maybe you'd like to see that is specific to infection control that we may not have covered? Is there anything you can think of other than handing you a TB policy and procedure manual? Because that's kind of hard. You really have to customize. Even if you are in a Department of Corrections facility, and that's a state prison, when you look at state prisons, usually it's governed by one policy and procedure. The challenge becomes if you're in an area that has very little TB and you almost never see TB, do you have to do the same things as an area in that whole Department of Corrections as everybody else who sees TB on a regular basis? Chances are there may be a few things that you don't have to do, or that based upon your risk assessment of your facility may be a little different. So those are some of the things. With that, what I'd like to do is actually turn the time over to all of you while we have Sue here and myself. Have you ask some questions. What have you learned, or what is it that we might be able to assist you with for the future as well? So I'm going to have you go ahead and unmute your phone, *7.
And this is Sue. And keep in mind, too, that if you're thinking of a question or something that you would like to voice, if you're thinking, at least one other person in that group is thinking the same thing. So don't be afraid to step up and say, what else? What could I have learned?
hope I got that question right on the board there, Ellen and
Yes,
Sue.
yeah, thank you
Change it, I
very
can. Okay.
You type so much better than I do. Thank you. Do a better TB screening of inmates. And actually, in our 6.5-hour webinar, we actually kind of go over that, and we have a skit in the middle of that that helps people to understand a little differently how they can screen or talk to the inmates and find out just a little bit more information. I always, I think it's so much easier to see somebody doing something so you actually can help yourself and your staff instead of rather, looking at here's the policies and procedures, do this, do a better screening. When would scripts need to be repeated? Is that for LTBI or for TB? And if you want to ask a question verbally, you can do that as well, but I like the written ones. These are actually quite cool. Screening protocols for small jails.
That whole part-timer.
Yeah, the screening protocols in small jails, this is where your security staff really needs to be taught and instructed on what to do in case of and this is where your policies and procedures and protocols will come into place, because your security staff is going to be your frontline people. They're going to be with them more than you are. They're going to see them more often than you are, and they're going to be the person that's going to actually see the person when they first come in. So they're going to need to be trained how to recognize these symptoms. And usually a lot of these are people that are coming back into jail. Some are for the first time, but a lot of them come back. So they need to have a way of contacting you or know what to do with this inmate if he comes in and they suspect him as having tuberculosis.
Hi, this is Nurse Bogart talking to you from GovCI.
Hi, I got your message.
One of my questions that I'm really work hard on, and that's that, when they come in, now they seem to have the option that they can refuse to take INH and B6, correct? They can refuse to take it?
Yes, they do. Yes, they can.
Yes.
And it's just so complicated. I mean, it's hard for us over here because if they are exposing the rest of the inmates in that cell or in that dorm, then, I don't understand. I would like to see that change, I guess is what I'm saying.
Do you want to answer this one, or
go
ahead?
Either one of us, we can both jump in, Ellen, on this one. If they're getting just INH and B6 and they are they're giving prophy for latent TB infection,
right,
then they have the right to refuse. But they also have to document that they had education understanding what they are refusing and why they are refusing it, because they have to understand that they have a chance of developing active disease. They're not exposing anybody. They're not contagious when they have LTBI because it's encapsulated. It's not active disease. They've just been exposed. So the tuberculosis is not. They can't give it to other people. But they need to understand the difference, and they need to sign off, and this would be something in your policies and procedures, something to sign off that they have been explained the purpose of the INH and B6, right, and they refuse to take
all
it.
That.
Yeah, and just
document
it.
It can come up and become active, right, because we're no longer testing them.
Correct.
We just do the questionnaire.
Uh-huh.
And what you need to do, and that brings it right back to your screening policies, are you screening at every encounter, every medical encounter, because they have the opportunity, they have the ability to possibly break down with active disease. Now you want to look at their sick calls. Some facilities actually monitor them for the first 2 years because if you are a new converter, you have a greater likelihood of converting your skin test and progressing to active disease within that first 2 years of becoming a contact. So some facilities actually monitor them every month as if they were coming in for their medication, but they're just checking to see, have you had any symptoms, any cough, any fever, weight loss, those kinds of things. And it's a dramatic weight loss. It's not a gradual, okay, I'm trying to lose weight.
Right.
Fevers as well. Are you all of a sudden seeing, okay, they're putting in increase in sick calls, those kinds of questions. So you want to put something in place so that you're actually seeing that this person was an LTB or a TB conversion, even if they're a reactor and now they keep coming back because they are on drugs now and having real issues, or they've just become diabetic and their body is stressed, or HIV. These are the ones you really want to target and make sure that you put something in place that you're monitoring them at every health encounter.
And it also includes making sure your healthcare workers are educated towards this, because they will, once that positive PPD and they refuse the INH, that may go straight out of their minds. And then they're not thinking about it each time they see them at the encounter. So that this is where your healthcare providers, both your doctors and your nurse practitioners and your sick call nurses, have to make sure they're looking at that also.
Okay.
And the other piece to that is that if they are active disease, they cannot refuse their TB medications. If they do refuse, you have an obligation to protect the rest of your facility. And so you have to put them in a working negative AII room, negative airborne infection isolation room, and keep them there until you can get a court order to actually give them the medications. And if you can't get that court order, or for whatever reason they're still refusing, you have to give them education on a regular basis and just keep them in there. At some point, they will have to understand TB is going to kill them.
Right.
That's a deadly disease if they're not treated. And so that may become a mental health issue, and you may have to talk about, and look at that. And we talk a little bit about that in our 6.5-hour webinar or training. So that is something that if anybody is on the call and have not participated in that, we really want to encourage you that you go ahead and sign up for that one as well.
Okay. Ellen and Lynn, I have and Ellen and Sue, I have another question that's come in through our Q&A.
Okay.
Yeah, I'm sorry.
When she comes back, can you sit here?
Could you go ahead and mute your phone, please?
They're going to have me do something when you hang
But
up. And
I think that's Sandra.
Yeah.
Or whatever.
Sandra?
Yes, ma'am.
Hey, could you mute your phone, please? Star
Yes,
6.
ma'am. Sorry.
Thank you. That's okay. Okay, so we have a question. I recall reading somewhere that corrections should have access to DOH TB labs to get AFB results online. I don't remember where I read it, though. Was that the CDC?
It is a recommendation. It's not a requirement. Not all states have that, but I do know in a couple of states, especially Florida and I believe Georgia, and I believe Ann Poole is on the line, as well as Valerie. You may be able to help with that question, but most states, it is a recommendation that you utilize your state lab, because those are the ones who are going to be able to identify and do the correct testing on it as well. And they all report to the state health offices any TB cases. So, Ann, can I get some input, maybe? Maybe not. Okay. And I know there's
Unmute
I'm
your
sorry,
phone.
what?
Just a reminder for them to unmute their phone. They press star 7 on their phone pad.
Correct. Thank you, Donna. For all of those who are technologically challenged like me, I have Donna to keep me straight. Thank you.
I am getting some responses on our Q&A.
Perfect.
Anne has responded that, yes, please send the isolates. Are you there? Hi. Somebody has hung up on us. If you could, star 7, please. Star 6. Star 7 to mute. Oh, my goodness. Wow. I have no idea who may have done that.
It makes me feel good, though, because...
Can you hear me still?
Yes, we
Okay.
do. But that is...
Bizarre.
Oh, no. Okay.
Here we go.
Thank you.
Yay. No, okay. All right. Well, Anne responded, yes, please send the isolates to the state lab.
Perfect.
I also have a response back from your DOH TB labs information. The problem is getting the results. And I think that might be within Florida. So that may be a follow-up separate from here. I have the name, and you guys could probably follow up with that.
Yeah, because if they're having a problem in Georgia, Florida, there shouldn't be a problem in Florida. You can call the state labs and actually have web access, but generally calling them very quickly can tell them, you can find out really quickly about what's going on.
Well,
Okay.
and I can tell you that in many areas, not just Florida and Georgia, but all over the United States, an issue is not getting the results timely. They may eventually get the results, but they don't always get them within 24 to 48 hours. And that's why it is so important to build that collaboration with your local health departments, because they actually will be getting that information in a timely basis. And sometimes there may be a lot of different areas in the correctional facility that might have come in, but you didn't get it.
Yeah.
Or the lab didn't have your fax number, or something else happened. That's where building those policies and procedures and really talking and communicating with your local health department, with your state health offices, that's where those loose ends can be really brought together. And so you have to have information. Who do you call? How can you get those results quicker? How do they even know you're a correctional facility? Those are some issues that are very critical when it comes to HIPAA and lab values and things like that you have to iron out in larger meetings. Getting that administrative team together and really thinking about every one of your policies and procedures, including adding laboratory diagnosis, laboratory results. Where do they go? And put that right in your policy and procedure so that you now have something concrete. You can go back and say, but we have something set up. We need to monitor this and make sure it's happening.
And also it can actually make sure that you're sending the specimens correctly, like we talked about. Make sure they're labeled properly. Make sure your people know exactly what needs to go on those slips, because that can also hold up the testing. They may end up throwing it away. Make sure you've got enough sputum in there for it to be tested.
Absolutely. And it's labeled appropriately. We had a question on the call.
Ellen, this is Ann.
Hi, Ann.
I just wanted to say that most all of our health departments would dearly love to work with their local jails to send in specimens to our state lab so that they are able to get the results back. I would highly encourage any partnership that could be made between any local facility with the health departments, especially concerning this.
Yes. Thank you, Ann, for that, because one of the things that Georgia is doing now is they have a corrections steering committee. They are trying to work very diligently with their local health departments and their correctional facilities to really tie those pieces together. And if any health departments are having challenges, they need to contact their state health office. And if they're not able to get through, we at the SNTC would be willing to work with you on a one-on-one, or, usually it's a three-on-one because it's that three-legged stool. If you don't have the health department and the administration and the medical folks all tied together, you may have a really wobbly stool, and meaning you have a very wobbly TB control program. So pulling those all together, we can actually assist with that when the state health office, bringing them in as well, is having some challenges. So all of those things, Florida, anywhere, we have what we call a mini fellowship. And if you are needing a little bit more information on TB in your facility, we can do a mini fellowship with you and work to help you identify some of those issues. So I hope that helps you as well. Think about those areas. Any other questions?
We are proactive in helping corrections and TB and health departments bridge a gap. It's very, very, very important. And Ellen and I both have a commitment to that. SNTC has a commitment to that. It is very important because we are community within a community, and we want to work. We all need to work together.
And we're all on this planet together.
That's right.
Any more questions?
Okay, if you have a question, you can unmute your phone by pressing *7 on your keypad. I'm not seeing anything on the Q&A board at this time. And I have posted the upcoming webinars for corrections so people can be getting that on their calendars. All of those will start at 10 o'clock Eastern Time and run very similar to the way we ran today's webinar.
We really encourage you, if you have the ability, to get on each and every one of these, because we will not have, although we don't have CEs available, continuing education units available for this, we will hopefully be able to, if you've attended all of them, we will have a certificate of attendance for you. Kind of helps a little bit when you're, looking at all of these issues and you're trying to pull it all together. And each one of these will build on the previous webinar as well as that 6.5-hour webinar or stand-up training that we had.
And Ellen, let me just mention in the accreditation standards, they are required to have so many contact hours. They don't necessarily have to be CEUs, but they have to have educational hours, and they have to be. There's a minimal requirement for each healthcare worker. So this will go towards that. They don't have to be CEUs. They can be attended workshops and webinars like this.
Yes. And in addition to that, Corrections has recognized that these are very valuable for their officers as well and count as training. So they can use that as well.
I have two questions that have come in. These both have to do with the sessions themselves. Can we download this PowerPoint? I've gotten that question a few times here. That is not currently one of our handouts, but I will add that to the list of handouts that can be grabbed from our from the SNTC website. So if you go out to the SNTC website on the home page, there's a section that's called What's Happening, and you'll see a list of entries there. The very last entry has to do with our webinar from today and getting handouts. You can click on that entry, and you'll get a list of handouts that you can select and download. We will leave that up for a few days. I will, as soon as we get done with this webinar, I will add the PowerPoints as one of those options. There have been several requests for that. Also, we are being asked, how do we register for the upcoming webinars? The upcoming webinars will be available to register from our site, our website. They are not out there listed yet today. We have everybody's email who registered today that registered for today's course, that we can get that message out to each of you, and we'll also disseminate the information the same way we did for this webinar. So we will get that information out to you, but if you're not seeing something, a week or two before the course, please go out to our website and look under our courses, and this will be one listed.
And I see a question that someone wrote on there about asking if CEUs are available for this. And unfortunately, CEUs are not available for these webinars, for these specific webinars. But if you think that that's something that you would like to have, we can certainly look at the upcoming ones and maybe address that as well.
And we also have many of our archived webinars have CEUs available. If you are interested in looking at some of the other topics that we have covered that are TB specific, not necessarily corrections, although there is even a corrections one on there. you are able to get CEUs from watching those. So and again, that's on our website, and it's under our training, and it's the archived webinars.
There is a tab for archive. Thank you, Donna. Yes. One question that I had from those of you, would you be interested in seeing that 6.5-hour training, and how would you be interested in seeing that? Would you like to see it as a stand-up training, which is what we did in Georgia, or as a webinar? And as a webinar, would you like to see that as maybe an all-day webinar where you're just carving out a chunk of time, or and would you rather see it as maybe 2 or 3 separate webinars? We can break it up into different pieces. And we'd really like to see how many of you who have not been to that training, how many would actually like to see that.
Okay, I was just doing
Donna,
a poll here.
Boy, you're good, Donna.
Sorry, it took me a second, but there, and that this is for, if I'm understanding correctly, people who haven't taken that training yet, right?
That is correct.
Okay.
It really is a TB Basics best practices. So it really talks a lot about transmission and some of the challenges that really do occur.
Okay, we've gotten a few people to respond. I think a few more are continuing to respond.
Good.
We can leave this up for a few minutes. That's fine.
Perfect. And it's important to have this kind of feedback because we really need to find out, you know, who truly is really wanting this kind of training.
And for those of you that are mentioning that you would love to have this in the classroom, we want to be sure that that's going to be a realistic possibility for you. I know in some situations that has been restricted, and but if you are able to travel, that's great. So if you are one of those 4 that have said in the classroom and travel, if you are able to do that, great, leave it there. If that's not a reality for you, let us know which of the other 2 options you would be interested in.
Great.
Okay, Ellen, is there any, or Sue, either of you, anything else that you want to get covered today?
Now, I just wanted to thank everyone for attending because it's so important that we realize the importance of stopping TB before it gets into our facilities and gets back out into our communities. And I take my hat off to both the health department because they have a tough job, and the correctional staff, they have a hard job. So working together, we can all work together to actually decrease the transmission within our facilities and therefore decreasing it out to our communities.
Sue, I couldn't say it better myself. That's exactly what I was going to say because I really, my hat is off to everybody who is out there trying to combat TB. And it's not an easy task. TB is one of those diseases that could be mirrored with any other disease. The flu is one of the ones that I'm thinking of that first and foremost. It is a challenge. It is an airborne disease. It is not easy to be able to recognize, and it takes a little bit of time, as we'll find out in the contact investigation course that we're going to do. Very important, though, every one of you, if you think you see TB, think TB. Don't think of it as something else and try to rule out everything else first. Think TB first, rule it out. It's cheap, it's easy. Do the sputums, do the chest x-ray, do all of those things that are required. And then, once you've ruled out TB, go on to your $1 million workup. It's like the duck theory. If you see a duck, or if you see something that waddles past you and it's quacking, it's probably going to be a duck. So don't let it lay an egg. You really want to make this work for you and keep your facilities safe. And like Sue said, you will then keep the community safe as well. So good. We've got quite a few people who said they really want the face-to-face training, 55% of them, and three of them said the 3 webinars, 2 hours each, recognizing that may be, fairly easy to do and won't take you so far away from your job. So that's not a bad thing. All right.
All right,
Thank
Ellen,
you
we are
all.
at 12 o'clock on the nose, right at
Perfect.
the time we said we'd be done. So,
I think that is wonderful. Thank you all very, very much for attending.
And thank you,
we
Donna
still have-
and Donna and Ellen, for getting this together.
You're welcome. And we will have an evaluation being sent to you in the next day or so. So we really would like you to complete the evaluations. We want to know how we're doing and what, you want to see. So it'll give you a little time to think about it. Thank you, Donna.
thank you all.
Thank you,
Thank you, everyone, for attending and being so involved in this webinar. We appreciate it, and we look forward to seeing you again on the next one.
Thank you.
So long.
Bye.
Thank you.
Bye, everybody.
Bye.